Hi, my name is Christine Sperduti, and I'm an on-site health coach supervisor at UPMC Health Plan. I'm also a current doctoral student studying at California University of Pennsylvania. Thank you for participating in this presentation on the Exercise is Medicine initiative with a focus on obesity treatment and prevention. Our objectives for the presentation include understanding what the Exercise is Medicine initiative is and its mission, recognizing the conditions that can be treated with exercise and how to discuss exercise with our patients in a client-centered way, understanding exercise prescription and special considerations specifically for the obese population, and then applying these new knowledge and skills to patients presenting with obesity. And lastly, we're going to identify some opportunities to use this information in health coaching practice and ways to promote the Exercise is Medicine initiative in our workplace. So before we get started, we are going to do a little pre-test just to check what you already know. And then at the end, we're going to take this test again and go over the answers. So if you could just take your phones out. For those of you with an iPhone, you can just use your camera function. If you have an Android, you're going to have to use your QR reading app. And you're just going to pull up either that app or the camera, and you're just going to hover over this QR code. And a link should pop up at the top of your phone if you're using an iPhone that says Open Forms in Safari. You're going to open that link, and that should take you right to that pre-test, and you can complete that. So I'm going to pause here for a moment and let you do that. So what is Exercise is Medicine, and what are the goals? Exercise is Medicine was founded by the American College of Sports Medicine and the American Medical Association in 2007. This initiative came from a switch in healthcare models due to the Affordable Care Act in 2010 and the HITECH Act in 2009. So this legislation called for a switch from volume-based healthcare to value-based healthcare because it's more low cost and high quality. The goal of Exercise is Medicine is to establish physical activity as a standard in healthcare. And again, this really is because of the switch from volume-based healthcare to value-based healthcare. Another goal of the Exercise is Medicine initiative is to connect clinical and community care. So why is Exercise is Medicine important? Well, first of all, 20% of patients drive 80% of healthcare costs. So these are going to be our patients with chronic diseases that are extremely costly to treat and to manage. Of all contributors to overall health, our health behaviors such as physical activity, diet, and smoking contribute 50%. And only 4% of healthcare cost is spent on promoting health behaviors. So you can see that there's a huge opportunity here to reduce these chronic disease rates by increasing our physical activity, changing our diet, cutting back on smoking, all things that we can control. And lastly, 65% of patients would be more interested in exercise if it was recommended and advised by their physician. So again, you can see that this is something that we can control very directly. The target population of the Exercise is Medicine initiative are rising risk individuals who are at risk of chronic disease without intervention. And the goal of intervention with an Exercise is Medicine professional should be to achieve self-management. So you can see the chain of events here where a patient would meet with their physician. A physician would prescribe exercise to manage or prevent their chronic disease. The patient would then be handed off to an Exercise is Medicine credentialed professional, and the patient or the professional or both report back to that doctor. If you're listening to this presentation and you're in a health and wellness field, you probably know that getting people to change their behaviors and their habits is not easy. So let's take a look at a couple different models of behavior change. The first model of behavior change is the ecological model. This model suggests that environments and policies need to be supportive of health behaviors for them to happen. When all of these are in place, individuals are more motivated and they feel more educated and more empowered to make and keep their changes. The health belief model is based on 4 different factors, and these factors are severity, susceptibility, benefits, and barriers, and the person's perception of them. So, for example, if someone's trying to convince me to get the flu shot, and I, think using this health belief model, I'm going to think about the severity of this condition. So, if I get the flu, how bad is it really going to be? I'm going to think about my susceptibility. Am I around people who get the flu? Am I around older people? Am I around babies? I'm also going to think about the benefits and the barriers. The benefits might be I know I won't get the flu, whereas the barriers might be I have to pay for it, I have to schedule an appointment with my doctor. So all 4 of those factors are going to play into whether the person decides to make change or not. In the trans-theoretical model, individuals move through behavior change in different stages. There are 6 stages of change in this model: pre-contemplation, contemplation, preparation, action, and maintenance. There's another stage of change called termination that's not part of the original model and is not used quite as often for talking about health-related behaviors. There are different strategies and different behavioral techniques that are most effective for moving people from stage to stage. But right now, we're just going to talk about kind of the definition of these different stages and how to identify a person in each of these stages. The first stage of change is pre-contemplation. In this stage, people are not intending to take action in the foreseeable future. Usually within the next 6 months, they are probably not planning on making a change. For example, a smoker who does not want to quit smoking, they have no issues with it, they're not concerned about their health. That would be an example of somebody in pre-contemplation. In contemplation, someone is intending to start the healthy behavior in the near future, so probably within the next 6 months. They might know that they're going to have some roadblocks, they're going to be a little bit more thoughtful, they're going to weigh the pros and cons before they get started. They may feel ambivalent in this stage, so kind of on the fence is how we describe ambivalence. The next stage of change is preparation, and in this stage, people are going to take action and make that change within the next month. Most people are going to start taking steps towards that change. So for example, if someone is, their goal is to run their first half marathon, someone in preparation is probably looking up training plans, talking to friends who run. They might join a gym that they know they can run on the treadmill at. They might be joining a running club. They're taking all these small steps to get ready. Action is when people have changed their behavior within the last 6 months and intend to keep doing it. They may acquire new healthy behaviors in this stage. They may not be as consistent as they'd like to be, but again, they're actively doing the behavior. And then lastly, in maintenance, individuals have been doing that behavior for at least 6 months and intend to keep going forward. In this stage, people are at the highest risk for relapse, which is going back to a previous stage, and there are different strategies to combat that. But again, maintenance is when somebody is doing it, they're doing it consistently, and they feel good about where they're going. The self-regulation theory talks about 6 ways to achieve self-regulation through self-monitoring, goal setting, feedback, self-reward, and self-instruction. So again, if you think back to that earlier slide, the goal of this program and the goal of working with an exercise is medicine credentialed professional is to get to the self-regulation stage where people can manage their own exercise and they don't necessarily need this professional anymore. With that being said, there is not one model that is 100% right or wrong, and usually it's a combination of many different models that makes a successful intervention. So we just wrapped up with our models of behavior change, and if you're from a health and wellness background, you know that these models are a really nice way to kind of look at our members and our clients. However, it's one thing to read on paper, and it's another to actually talk with a client, talk with a patient, and get them to make the change. So our next section, we're going to talk about how to communicate with our patients in a client-centered way. The first method of communication is called the 5A technique. The 5A's stand for ask, advise, assess, agree, and the last one is a combination of assist and arrange. And these really speak to your role as the exercises medicine professional. So the first A is ask. So ask what you can do for your client. We never want to impose our ideas and our opinions on our client, so this is a really good way to start off a conversation, get their guard down. We don't want to put them on the defensive right away. So we're going to ask what we can do for them. Next, we're going to advise our client on healthy steps to take. Because we've already asked them, they know we're trying to help them, and again, they're not going to be as defensive and resistant to this information. Next, we're going to assess the client interest in the changing behavior. So we're going to refer back to maybe those stages of change and assess, is this person in contemplation, pre-contemplation, maintenance? Where are they in their behavior change journey? And after we assess the interest in changing behavior, we're going to agree with whatever approach the client selects. So in the next communication style, motivational interviewing, we will learn that, again, all of these are client-centered, and we assume that the patient knows what's best for themselves. So we're going to agree with whatever approach that the client thinks is right for them. They're the experts of their own body and their own lives. Next, we're going to assist and arrange the client in modifying the behavior, connecting them to different resources, and always we're going to offer that follow-up support. The next communication method is motivational interviewing. Motivational interviewing is used quite often in the health coaching field. The spirit of motivational interviewing is collaborative, so we're really partnering with our clients instead of putting on our expert hats. It's evocative, it honors autonomy, and so for those reasons, it's extremely client-centered. When we are using motivational interviewing, we're avoiding argumentation, we're expressing empathy, we're rolling with that resistance that we might get from our client. And in this approach, we're really developing discrepancy in our clients between where they are and where they want to be. We could have an entire presentation on motivational interviewing, so I'm just going to leave you with some practical tips. So the first acronym that's really helpful to remember when trying to implement motivational interviewing is that when you get stuck, to remember to pull out your oars, which stands for open-ended questions, affirmations, reflections, and summaries. So these are going to be our key skills in motivational interviewing. So an open-ended question is just a question that a patient cannot answer with yes or no. So instead of asking a patient, do you plan on exercising in the next 6 months, which they would say yes or no to, we could ask them, what gets in the way of getting started with exercise? And that question is going to give you a lot more information than you would have gotten with a closed-ended question. Giving the client affirmations when you really mean them is going to be very impactful for that member. Again, honing in on their skills and their qualities, their hard work, their dedication to what they're doing. Reflections let our clients know that we're listening to them. So if a client is telling you all about their barriers, reflect what you're hearing to them. It can be as simple as saying, I hear that you're trying really hard, but work is getting in the way. Again, just letting them know that you're listening and you're invested in the conversation. With that being said, summaries are a really good skill to use to kind of wrap up parts of the conversation and transition to the next. So maybe you did ask that member the question about, what's getting in the way of starting exercise. They give you a bunch of different answers and you kind of summarize that. So what I'm hearing is time gets in the way, along with the lack of support from your husband. You have to cook dinner and do laundry and take care of the kids after work, and that's really challenging to fit in. And then that's a really good segue for another open-ended question that might trigger some more conversation. Another practical tip is to listen for change talk. So change talk is going to indicate to you that this client is going to be more likely to change and is maybe thinking about change. And an acronym to remember this is DARN CAT. And this stands for 6 different types of change talk you might hear, which is desire, ability, reasons, need, commitment, and taking steps. So desire is going to be a statement about how they want to change. I really want to lose weight because. Ability is statements about their capacity to change. So you might hear someone say, I know I can do it if. You might hear reasons for change. So somebody might say, I know my blood pressure is really high and I need to change my diet. And then you might hear statements about feeling obliged to change or needing to change for certain reasons. And then the last two, commitment and taking steps. So these are statements that indicate to you that this person is a little bit more committed. So maybe they have joined a gym, maybe they have talked to their spouse about the things getting in their way, and then thinking about all those statements that the member is taking action to make change and really latching onto that change talk. And again, using your oars to continue that conversation and dig a little bit deeper with this client. So now that you have been equipped with a crash course on behavior change models and some communication strategies, let's move into the focus specifically on conditions that are covered in this Exercises Medicine initiative, and then we'll dive into obesity specifically. The Exercises Medicine initiative is founded on the research that shows that an exercise capacity of less than 5 METs increases the risk for mortality. However, an exercise capacity of at least 10 METs is associated with good long-term health outcomes regardless of the presence of coronary disease, which is really great to know. Exercises Medicine offers guidelines for exercise for a lot of different conditions, including mental health, rheumatoid arthritis, low back pain, chronic pain, osteoporosis and osteoarthritis, obesity, type 2 diabetes, multiple types of cardiovascular disease, aging and fall prevention, pregnancy, and cancer. For the rest of the presentation, we're going to focus on managing obesity with exercise based on the Exercises Medicine guidelines. While it may be hard to think of obesity as a chronic disease, obesity is an independent risk factor for many other chronic conditions such as diabetes, cancer, and heart disease. Improved fitness decreases mortality with each MET increased. It's actually about a 10 to 18% increase per MET. And lowering body weight by just 10% is clinically significant and improves health, mobility, and the risk of the chronic diseases listed above. So you can see that managing obesity and treating obesity is really important for the individual. It's really important for our government healthcare spending. It's important for a lot of different reasons. So we are going to run through risk stratification very quickly. So please feel free to pause this presentation and read over this information after we run through it if you need more time. So the American College of Sports Medicine has designed a risk factor stratification flow for determining if somebody is at high risk, moderate risk, or low risk when they're starting an exercise program and what we should require of this person before getting started. So if somebody has known cardiovascular, pulmonary, or metabolic disease, or if they have signs or symptoms of these, so things like heart murmur, intermittent claudication, dizziness, syncope, ankle swelling, shortness of breath. So again, known disease or any of these signs or symptoms, they are automatically going to be high risk, and medical clearance is recommended for any type of exercise, so moderate or vigorous exercise. If somebody does not have known disease, they don't have any signs or symptoms, but they have 2 or more of the risk factors that are on this slide, they are going to be put at moderate risk. And with a moderate risk, for vigorous activity, a medical clearance is recommended. For moderate intensity, it is not required. So again, that's 2 or more of these risk factors. For less than 2 risk factors, so 1 risk factor or no risk factors, this person is going to be at low risk and they do not need medical clearance for moderate or vigorous activity. So, just reading through these risk factors very quickly: age, family history, smoking, sedentary lifestyle, BMI, hypertension, high LDL cholesterol, and blood sugar. So, now we're going to dive into some recommendations surrounding exercise for obese clients specifically. So, we're going to separate this into aerobic and resistance exercise. Our recommendations for aerobic exercise include exercise that is 40 to 60% of the peak heart rate. So if somebody's low risk, they can push that a little bit. But for most of these clients, we're going to stick to around 40 to 60% of that peak heart rate. We're going to aim for 5 to 7 days per week for a total of at least 300 minutes of moderate to vigorous physical activity. So you might know that the general guideline is 150 minutes a week for heart health. So you can see that this recommendation is double that. And that's going to be really important for weight loss and weight maintenance specifically. It's important to remember that duration is more important than intensity in these individuals, and we should also be encouraging them to move more throughout the day, not just focus on activity that's structured. Switching over to resistance, a lot of individuals who are obese and are looking to lose weight overlook resistance because it doesn't burn as many calories. However, as exercise professionals, we know that muscle is more metabolically active, and it's really important to build lean muscle mass to increase metabolism in these individuals. So, for resistance exercise, we're going to do 40 to 50% of their one repetition max, and we're going to shoot for 2 to 3 days per week. And you can see that we're going to do a little bit lower in sets and a little higher reps. So again, focusing on that duration, that endurance more than the intensity. So we're going to do 1 to 3 sets, 8 to 15 reps. While it might not be your first inclination to ask about medications when working with an obese individual, it's very important because appetite suppressants may increase blood pressure and can cause an increased response during exercise. And that's really important for you to know as their exercise professional. So here are a list of just a couple common appetite suppressants with their drug name along with their the brand name. And again, it's really important to ask your clients what medications they're on, being aware of medications they may be taking for other conditions, not necessarily obesity, and then being aware of non-prescription medication as well, as a lot of people seem to be turning towards these over-the-counter supplements, natural supplements, and those can play a role in exercise response as well. When working with obese patients, it's important to remember that some of them might be recovering from bariatric surgery or considering bariatric surgery. They might be doing a program to qualify for bariatric surgery. So I wanted to take a moment to discuss some of the common types of weight loss surgery that you might hear about, just so you have kind of a basic understanding of the process and the procedure. So the first is gastric sleeve. So this process removes most of the stomach, leaving a small section closed with staples. So this surgery reduces the amount of food someone can eat, and it can't be reversed. So if you look at letter A, that's going to be your gastric sleeve. Gastric band is an inflatable ring used to create a small pouch for a stomach, so they're going to feel full with smaller amounts of food. And the good thing about this is it can be reversed and it can be adjusted per patient. Next is gastric bypass. So it has two parts. The first part is when the surgeon staples the stomach, creating a small pouch in the upper section. So again, the staples make the stomach smaller, you eat less food, and you feel full sooner. Next, the surgeon cuts the small intestine and attaches the lower part of it directly to that pouch. So when they do this, food bypasses most of the stomach and the upper part of the small intestine, which is where the food really absorbs into the body. So by bypassing that small intestine, your body absorbs fewer calories. The surgeon connects the bypass section further down to the lower part of the small intestine. So the bypass section is still attached to the main part of the stomach, so digestive juices can get from the stomach to the intestine. But the bypass changes gut hormones, gut bacteria, and other factors that may affect appetite and metabolism. It's really difficult to reverse, but it can be done if needed. And then lastly is a duodenal switch, which involves two separate surgeries. The first is really similar to gastric sleeve. The second surgery redirects food to bypass most of the small intestine, and then they reattach the bypass section to the last part of the small intestine, which allows the digestive juices to mix with it. This type of surgery allows you to lose more weight than the other three. However, it's also the most likely to cause surgery-related problems and a shortage of vitamins, minerals, and protein in the bodies. So for these reasons, surgeons don't usually do the duodenal switch surgery, so you're probably going to see the gastric sleeve, gastric band, and the bypass surgery most often. It's really important to know that rapid weight loss because of these surgeries may cause lean muscle mass loss in your patients, which can lead to balance issues, weakness, fatigue, and they also can cause severely impaired exercise tolerance. So with these patients, so if you're working with somebody who's recovering from bariatric surgery or is getting started on this exercise journey after bariatric surgery, it's really important to start with 5-minute bouts and increase duration before intensity because, again, 5 minutes might be all that they can do at first. Outside of medications and bariatric surgery, there are a couple other general considerations. So in obese individuals, overheating is going to be much more likely, so it's important to stress proper hydration. Keep in mind the equipment size when you're working with these patients, recommending exercises, as some of these machines may not be, an obese individual might not fit in them, and it could be very uncomfortable or embarrassing. And again, be mindful of the presence of other comorbidities this person may have. Again, if this person is moderate risk, a graded exercise test may be recommended for vigorous activity. It's important to avoid high impact activities, postural changes with these people. High impact activities is going to be really stressful on joints, especially with extra weight. And postural changes, so going from standing to laying down, is going to take more time and it's going to be much more taxing on an obese individual. Lastly, keep in mind the seat positions. So going back to that equipment size, making sure that everything is properly fitted to your patient or your client. And then lastly, recommending proper clothing. So chafing might be more prevalent in these individuals. So encouraging them to wear, that dry fit clothing that's going to cover to reduce that possibility. While exercise is very important for managing and treating obesity, we know that it is best practice to integrate diet and exercise for weight loss. Right now, the guideline for overall heart health is 150 minutes per week. However, that guideline jumps to 300 minutes of moderate to vigorous physical activity per week for weight loss and weight maintenance. So that's going to be kind of our gold standard to shoot for, is at least 300 minutes. In addition, we're also going to help these members, these clients, create a calorie deficit by reducing the number of calories consumed through food or increasing the number of calories that they're burning with exercise, or best practice, a combination of both. So again, really encouraging the combination of diet and exercise and making the appropriate referrals to a registered dietitian if necessary. Now that we have covered all sorts of different information about the exercise as medicine credential, behavior change theory, communication techniques, obesity specifically, we're going to take a look at a case study, some information about an individual, and just jot down any notes that you can think of. So what stage of change that this person might be in, their risk factors, what you might recommend for this person, some things that you may or may not want to know about this person. And I'm going to give you about 3 minutes, and you can just pause the recording, and if you don't need that much time, pick right back up. But I'm going to give you some time to read through this and make some notes, and then we'll just run through a couple of different things. Okay, so if you didn't have enough time, you can go ahead and pause the recording. If you are good to go, we're just going to move forward. So you can see that this person is a 35-year-old female who is not currently exercising, but mentioned that she wants to be a good role model for her daughter by being more active. This person has no known disease and no signs or symptoms of disease. So let's start with their stage of change. So this person has mentioned that they would like to start exercising to be a good role model. So this person might be in that contemplation stage. So they're thinking about making a change in the next 6 months. We've heard some of that darn cat change talk. So again, desire, action, reason, need. This person gave you a reason. They want to be a good role model for their daughter by being more active. So again, when we talk to this patient, this client, we want to make sure that we're very client-centered, asking what might work for them, using our motivational interviewing skills, pulling out our ORs, so our open-ended questions, affirmations, reflections, and summary. So by looking at this person, they have no known disease, no signs or symptoms of disease, so they are not going to be a high-risk individual. We know that, but now we're going to look into those risk factors and see if we can identify what they might be. So right off the bat, we can see that she's 35, so age is not a risk factor. She's a non-smoker, that's not a risk factor. She has no family history, not a risk factor. So looking at the BMI, it's greater than 30, so we're going to jot that down as one risk factor. Blood pressure, while it's a little higher than we'd like, it is not higher than 140/90, so our blood pressure is not going to be a risk factor here. We're going to look at that HDL and the LDL next. So the LDL is higher than 130, HDL is higher than 40, but that LDL is a little bit higher than we'd like it, so that's going to be our second risk factor, meaning that this person is going to be at a moderate risk right off the bat. You can also see that fasting glucose is 105, which puts her over the threshold for that's 100 usually. So 3 risk factors, she's going to be moderate risk. Exercise test by a medical professional is recommended for vigorous activity only, but we can proceed with that moderate intensity activity, no problem. And again, keeping in mind all of those guidelines for obesity. So our low impact activity, avoid postural changes, hydration, referring back to all those slides that we covered earlier. So anything that you wrote down from those slides is going to be relevant here. In conclusion, just a couple take-home points. So the first is that the Exercise as Medicine Initiative's goal is to establish exercise as a standard in healthcare. And there are many different behavior change models that each play a role in helping the population make lasting changes, especially when it comes to exercise. But overall, client-centered communication is really key. Exercise is not only encouraged, but is recommended for obese clients, and the best practice is by integrating diet and exercise for weight loss and weight maintenance. So now that we've had all this information, we've covered the Exercise as Medicine Initiative, behavior change theory, we've covered communication strategies and obesity recommendations. We're going to take a post-test, which are the same questions that you saw at the beginning. We're just going to compare our answers. We're going to go over the answers, and then we will move on. So go ahead, take out your phones. Again, if you are using an iPhone, you can use the camera. If you are using an Android, you're going to need to pull up that QR code reading app. If you have any questions at all, please feel free to contact me. My email and phone number are listed on the slide. If you have more questions or are more interested in the Exercise as Medicine Initiative, you can find a credentialing course and different resources at exercisesmedicine.org. And then one more QR code on the right is going to be for satisfaction survey, and I'm just going to leave this up at the end of the presentation. And again, you can use your phones to answer a few questions about this presentation and how it could be improved.